When you look at an MRI, it's incredibly tempting to just think of it like photography.
Oh, totally.
Right. Like you put the patient in the scanner, you press a button, and out pops this perfect high-resolution picture of their anatomy.
Like a snapshot.
Exactly, like taking a snapshot of a landscape. You assume the machine just passively captures reality. But, I mean, the reality of body MRI is more like trying to photograph a highly temperamental physics experiment.
That is a great way to put it, yeah.
Because you're actively manipulating magnetic fields and radio frequencies. And the landscape you're trying to capture, well, it's breathing. Its heart is beating.
And the patient might be in agonizing pain, too.
Right, which, fundamentally redefines the job of the person actually reading that scan.
It really does. If you treat a body MRI like a photograph, you are completely missing the dynamic, unpredictable environment where that image was even created.
You have to know what's going on behind the scenes.
Exactly. Without understanding the physics of what the scanner is physically doing to those tissues, and, the physiological state of the patient at that exact moment, you aren't really interpreting the image. You're just guessing.
And that brings us to the core mission of today's deep dive. For all the medical students, the radiology residents, or just the curious clinicians tuning in, we are jumping straight into the Mayo Clinic Body MRI case review.
It's such a fantastic resource.
It really is. And our goal here is to help you bridge a very specific gap, moving from just, passively reading images to actively understanding the real nuts and bolts of how they're acquired.
Getting into the science of the protocols.
Yeah, exactly.
Yeah.
From troubleshooting weird physical artifacts to identifying metastatic disease without getting completely bogged down in jargon.
Right, keeping it practical.
But to appreciate where body MRI is today, we kind of have to look at its historical baggage. The authors point out that for a long time, body MRI was treated as the weak stepsister to neurologic MRI.
Well, absolutely. The context of those early days explains so much about the mindset today. I mean, during the author's own training, the MRI schedule was entirely monopolized by neuro cases.
Because brains don't move.
Right. Brains and spines are just ideal subjects for a magnet. They're relatively still. They cooperate.
They don't have bowels digesting lunch.
Exactly. So if you were doing an abdominal imaging fellowship back then, you had to arrive at like 6:00 a.m. just to squeeze in a couple of body cases.
Wow, 6:00 a.m.
Yeah, before the prime time, 8:00 a.m. to 3:00 p.m. block, which was fiercely guarded by neuroradiology.
So the schedule was dictated purely by the physics of motion.
Completely. The development was hindered because you have respiratory motion, cardiac pulsations, bowel peristalsis just constantly blurring the image.
And on top of that, the torso has a really variable, odd shape, right?
Yeah, it couldn't easily be accommodated by a single, simple radiofrequency coil like a head can. It was a logistical nightmare.
But the pioneers of the field obviously persisted. They turned body MRI into this diagnostic powerhouse. But the authors note a sort of troubling modern consequence of that success.
Yeah, because the technology has become so automated now, training has actually become a bit haphazard.
Right. Residents are frequently interpreting images remotely. They rely on these rigid, standardized protocols, completely divorced from the physical reality of how the scan was even obtained.
And the text mentions structured reporting as a symptom of this. A radiologist might just check a box rating an image quality as poor or fair.
Which is like, it's like a race car driver confidently reporting over the radio that the car is handling terribly, but having absolutely no idea how to adjust the suspension.
Or change a tire, yeah. Passively rating an image is useless unless you can tell the technologist exactly how to fix the protocol.
And case 17.6 from the book is a brilliant example of this. So you have a 17-year-old woman presenting with chronic pelvic pain. The MRI comes up, and there's this massive, intense signal loss straight across the anterior pelvis.
Just a huge black void on the screen.
Right. Now, an untrained eye immediately starts hunting for pathology, or maybe a susceptibility artifact.
Right. And a susceptibility artifact happens when something, usually metal or sometimes air, distorts the local magnetic field.
It causes the signal to just drop out.
Yeah. So you might wonder, did she swallow something? Did she have a surgical clip?
But this void had absolutely nothing to do with her anatomy. The technologist had simply forgotten to place the anterior dielectric pads on her abdomen.
Such a simple hardware mistake.
Let's break down the actual mechanism there, because, dielectric effect is one of those terms that gets thrown around a lot.
Sure. So at higher magnetic field strengths, like a 3 Tesla scanner, the wavelength of the radiofrequency pulse actually gets shorter.
It approaches the physical dimensions of the patient's torso?
That is the crux of the issue, yeah. Because the RF wavelength is so short, you get these standing wave effects inside the body. The waves interfere with each other, sometimes destructively.
Creating a literal void where no signal is excited.
Exactly. And dielectric pads are basically these physical cushions filled with a conductive fluid.
Oh, okay.
When you place them on the patient, they act as a conductive bridge. They alter the local electrical conductivity and permittivity.
So they essentially smooth out that radio frequency field and eliminate the void.
You got it. And the authors actually looked at this patient's scan from a year prior where the pads were used and the image was flawless.
Wow.
But
So if
yeah,
you don't know the hardware setup, you are literally diagnosing a ghost.
you really are. Which means you can't just be a master of human anatomy. You have to be a master of the scanner's hardware.
But that physical manipulation isn't just external, right? The actual physics happening inside the microscopic tissue environment is where we find some of our most powerful diagnostic tools.
Chemical shifts are the perfect example of that.
Right. So when we are evaluating a patient for hepatic steatosis, so fatty liver disease, we are exploiting this tiny, tiny discrepancy in how water protons and fat protons interact with the magnet.
Yeah, because fat protons are surrounded by a denser electron cloud than water protons.
Think of that electron cloud as a microscopic shield.
Exactly. And because of that shielding, the protons in the fat molecules feel a slightly weaker magnetic pull from the main scanner.
So they spin or resonate just a tiny bit slower than the protons in water.
And that microscopic delay is the chemical shift.
The text specifies this shift is 3.5 parts per million. But because it's a relative ratio, the physical frequency difference changes depending on the strength of the scanner, right?
Right. The math dictates your imaging parameters here. At a standard 1.5 Tesla scanner, that 3.5 ppm difference means fat protons are spinning about 220 hertz slower than water protons.
Okay, but if you upgrade to a 3 Tesla scanner,
The magnetic pull is twice as strong, so that frequency difference doubles to roughly 440 hertz.
oh wow.
We use that known difference in speed to time our imaging. We capture one image when the fat and water protons are perfectly synced up. That's the in-phase image.
And then another one when the fat protons have fallen exactly 180 degrees behind the water protons.
Right, the out-of-phase image. So if a pixel has both microscopic fat and water in it, the signals cancel each other out on the out-of-phase image, and the tissue looks visibly darker.
It's just such an elegant piece of physics. That's how we prove a tissue has microscopic fat.
It is. But the authors issue a massive warning for learners applying this concept to adrenal adenomas.
Yes, this part was fascinating. Because historically, to prove an adrenal mass was a benign fat-containing adenoma, radiologists would measure its signal dropout and compare it to an internal reference standard.
Usually the liver, the spleen, or maybe skeletal muscle.
But the text explicitly warns against doing this now.
It is a total diagnostic trap. Because the moment you use the liver as a reference standard, you are assuming the liver is perfectly healthy.
Right, but what if the patient has a fatty liver?
Or what if their spleen has heavy iron deposition from some blood disorder? Iron causes its own signal loss on in-phase images.
So if your reference tissue has its own chemical shift pathology, your baseline is completely corrupted.
Your measuring stick is broken.
Exactly. If the liver is dropping in signal right alongside the adrenal gland, the relative ratio might actually look normal.
Which leads you to misdiagnose a benign adrenal adenoma as a potentially malignant mass.
That's terrifying. So you must evaluate the adrenal gland's signal dropout on its own mathematical merits, not relative to a potentially sick neighbor.
Precisely.
And this theme of tracking signal changes brings us to breast MRI kinetics, where we add the dimension of time to the physics equation.
Remember, we aren't just looking at spatial maps anymore. We are plotting signal intensity over time before, during, and after injecting a gadolinium-based contrast agent.
So we're essentially assessing the physiology of the blood vessel.
Yeah. When tumors grow, they undergo neoangiogenesis. They build their own blood supply.
But these new vessels are chaotic, right? They lack normal basement membranes.
They are essentially leaky, disorganized pipes.
The text notes that peak enhancement typically occurs within 2 to 3 minutes. And the authors break the curve into the initial phase before the peak, so slow, medium, or rapid, and the delayed phase after the peak.
And that delayed phase is the critical one. We categorize it as persistent enhancement, a plateau, or washout.
Because malignant tumors have those leaky vessels, they grab the contrast rapidly, but they also wash it out rapidly.
Right. Finding that delayed washout pattern is a much stronger indicator of malignancy than just seeing rapid initial uptake.
Now, to process these complex time-intensity curves for every single pixel in the breast, we rely on computer-aided detection, or CAD.
The software analyzes the kinetics and overlays a color map on the image.
And red usually signifies a rapid uptake and washout, which is a major red flag.
But the authors insist on reviewing the raw, uncolored images first.
This blew my mind. Because if these CAD algorithms can calculate pixel kinetics faster and more accurately than a human, why shouldn't we trust the red flags on the color map?
Well, it comes back to the oldest principle in computer science, garbage in, garbage out.
Okay, fair enough.
The CAD software is blind. It doesn't know what it's looking at. It only calculates numerical changes in a given pixel over a 4-minute span.
But when a patient is in the scanner for a breast MRI, they're breathing.
Exactly. If they take a deep breath or shift their weight even slightly, the tissue moves.
So the pixels in the first image don't perfectly align with the pixels in the fourth image.
And that creates a very dangerous illusion. Imagine the border between bright glandular tissue and dark fat.
Okay.
If the patient breathes, that bright tissue slides back and forth across a single pixel.
Oh, wow. So the computer registers a rapid spike in signal followed by a rapid drop.
Yes, it calculates a washout curve and paints that pixel bright red.
So on the color map, a linearly distributed red line along a tissue interface looks remarkably like ductal carcinoma in situ.
A very real, very scary breast cancer.
But if you look at the raw images, you can clearly see the tissue is just shifting back and forth.
You risk sending a patient for a completely unnecessary traumatic biopsy simply because a computer hallucinated over a motion artifact.
That is wild. The algorithm just doesn't account for the reality of the human body.
It really doesn't.
And human anatomy is incredibly unpredictable anyway, which forces a shift in how we approach the scan entirely. Let's look at the appendix.
Okay, great example.
A patient comes in with right lower quadrant pain. Standard textbook anatomy says the appendix originates from the cecum, typically 2 to 3 centimeters below the ileocecal valve.
That is the textbook standard, sure.
Yeah.
But human anatomy has vast normal variability, and physiology changes the landscape even further.
Like pregnancy.
Exactly. Take a pregnant patient in her 3rd trimester. That expanding uterus physically displaces the entire right colon.
The cecum and the appendix are shoved far upward, sometimes way up into the right upper quadrant near the liver.
So you can't just rely on a standard right lower quadrant protocol. You have to dynamically adjust your search pattern across the abdomen.
But when you dynamically adjust your search pattern, your field of view expands. You are hyper-focused on finding a displaced appendix, but what happens to your peripheral vision?
Right, you start seeing things you weren't looking for.
What happens when the scanner detects a completely unrelated problem? This is the classic incidentalomo.
Oh, yes. Case 14.1 is perfect for this. It highlights a 72-year-old man with a history of prostate cancer who gets a pelvic MRI.
And the scanner accurately detects fluid around the greater trochanter of his hip.
The machine did its job perfectly. The fluid is real.
But the dilemma is entirely clinical. What do you do with that accurate data?
Because if you report it as a prominent finding, the referring physician might order more tests, they might inject the hip, or even delay the patient's prostate cancer treatment just to investigate.
Which is why the authors advise downplaying or even completely ignoring minimal trochanteric fluid, particularly in older patients where it is bilateral and symmetrical.
It is almost certainly just normal degenerative wear and tear. You are acting as a clinical filter.
Right. Now, if the fluid collection is large and unilateral, you flag it. You scrutinize the gluteal muscles and tendons for tears.
But without that filter, you induce tremendous anxiety and unnecessary medical costs.
It's a delicate balancing act. It's like medical triage mixed with film editing.
I like that.
You have to capture the critical shot, but you also have to aggressively leave boring, irrelevant background details on the cutting room floor so you don't send the referring doctor on a wild goose chase.
Yeah, and that triage mindset becomes absolute life or death when we discuss rapid imaging.
Definitely. There's no scenario more urgent in this textbook than the intramural hematoma, or IMH.
An intramural hematoma is blood dissecting within the wall of the aorta, tearing through the media layer without an intimal flap.
These patients are in excruciating tearing chest or back pain.
They are terrified. They might be claustrophobic. They will not lie perfectly still for a 45-minute pristine, high-resolution MRI protocol.
They're going to panic, squeeze the emergency ball, and the scan will be aborted.
The author's fundamental principle here is to obtain the most important diagnostic information as quickly as possible.
To diagnose a subacute intramural hematoma fast, they recommend a pre-contrast MRA or an axial fat-suppressed 3D SPGR sequence. Let's dig into the physics of why 3D SPGR is the tool of choice here.
Okay, so SPGR stands for Spoiled Gradient Recalled Echo.
Right.
In standard MRI, you send in a radiofrequency pulse, listen for the echo, and then you usually have to wait for the transverse magnetization to naturally decay before you can send the next pulse.
And that waiting takes time.
Exactly. In a spoiled gradient sequence, you fire the pulse, get your signal, and then you intentionally spoil or crush the remaining magnetization using specialized gradient pulses.
Because you forcibly wipe the slate clean, you can fire the next pulse almost instantly.
It drastically cuts down the scan time.
But that speed comes with a significant trade-off. The text notes that 3D SPGR has a very low signal-to-noise ratio.
The image is going to look grainy.
Yeah, it will look grainy, but the authors suggest a completely counterintuitive pro-move. They say intentionally decrease the spatial resolution even further.
Which sounds crazy, right?
Why intentionally make the image blurrier?
Because of voxel size. A voxel is a 3D pixel. When you decrease the spatial resolution, you are making each individual voxel larger.
Yeah.
Think of voxels like buckets catching rain.
I love this analogy.
A larger bucket catches more protons. Because there are more protons in that larger voxel, they give off a much stronger, louder signal that easily drowns out the background noise.
So you sacrifice the fine, sharp edges of the image, but you massively boost your signal-to-noise ratio.
Yes. You get a highly diagnostic image of the aorta before the patient quits the exam.
That is a phenomenal clinical pearl. Optimized for the patient's tolerance, not for a photography contest.
Exactly.
Also, the text specifically notes that the classic bright high T1 signal only applies to subacute blood. It will not look bright if the bleeding is hyperacute and fresh, or if it's very old.
You have to know the timeline of the hemoglobin degradation.
Right. But while an IMH requires hyper-focused triage on a single blood vessel, some diseases require us to look at the entire systemic picture.
Like prostate cancer, for example. It has a high propensity to metastasize to the bones.
And this leads us to the cutting edge of the field, which is whole-body DWI, or diffusion-weighted imaging.
Cases 14.24 through 14.27 explore this as an emerging alternative to traditional bone scintigraphy, or PET-CT scans, for screening the entire skeleton.
The engineering behind whole-body DWI is pretty remarkable. The protocol breaks the patient's entire body into several stations.
And the scanner uses very high B-values, typically between 800 and 1,000 seconds per millimeter squared.
And the B-value basically dictates how strongly the magnetic gradients are probing the tissue for the microscopic diffusion of water molecules.
Right. When you apply a high B-value, you suppress the signal from normal background tissues where water moves freely.
But highly cellular tissues, like a dense tumor packed with cells, they physically restrict water molecules from bouncing around.
And because the water is trapped, it retains its signal and lights up brilliantly on the scan.
The scanner generates apparent diffusion coefficient, or ADC, maps to quantify this restriction. Then the software stitches all these body stations together into a 3D rotating image.
It visually mimics a PET scan, but you haven't injected the patient with a single drop of radioactive isotope.
It sounds like the holy grail of metastatic screening. I mean, it's exquisitely sensitive for detecting focal marrow lesions and performs very well compared to traditional bone scans.
The sensitivity is exceptional, but the radiologist must deeply understand its limitations.
Right. There's always a catch.
Its greatest flaw is a profound lack of specificity. Yes, dense tumors restrict water diffusion, but so do many benign pathologies.
Like what?
Well, an abscess packed with inflammatory cells restricts diffusion. A reactive lymph node responding to a basic infection restricts diffusion. Even the edema from an old bone fracture can show up as a bright spot.
So it acts as an incredible alarm system, telling you something is there, but it can't always tell you what it is.
Furthermore, whole-body DWI is notoriously poor at distinguishing between positive and negative lymph nodes if the nodes aren't visibly enlarged.
Right.
And if you detect a restricted lesion in a solid organ, like the liver or the kidney, the diffusion imaging alone is rarely enough.
You almost always have to follow up with a dedicated, dynamic, gadolinium-enhanced MRI to characterize the actual blood flow of that specific parenchymal lesion. Which brings us full circle. Before we synthesize all of these concepts, let's put our medical learners on the spot.
We've covered a vast amount of physics and physiology today.
So let's test your recall on one of the critical diagnostic parameters we discussed.
Think back to our discussion of breast MRI kinetics and the time intensity curves. When does peak contrast enhancement typically occur? And which phase of enhancement, the initial phase or the delayed phase, is more heavily relied upon as a primary clue to malignancy?
Take a second to mentally lock in your answer.
You should recall that peak enhancement typically occurs at 2 to 3 minutes. And more importantly, It is the delayed enhancement phase.
Specifically looking for plateau or washout patterns driven by chaotic leaky tumor
Right.
vessels.
That serves as the much stronger indicator of a malignant lesion.
If you synthesize everything from today, from the physics of dielectric pads fixing radiofrequency voids, to the electron shielding causing chemical shifts, to the triage of an intramural hematoma using spoiled gradients.
The core lesson of the Mayo Clinic body MRI case review becomes so clear. Great imaging interpretation demands active, relentless
You
engagement.
cannot just read the final images. You must understand the microscopic environment. You have to know how to alter parameters for a patient in distress and recognize the physical limitations of the algorithms processing your data.
The radiologist is not a passive consumer of photographs. They are the director of a complex, dynamic physics experiment that changes with every single breath the patient takes.
Which leaves us with a provocative thought about the future of this field. As our scanners become increasingly powerful, as stronger magnets and hyper-advanced algorithms spot every microscopic drop of fluid in a hip or every tiny benign marrow change across the entire skeleton.
We're going to be drowning in data.
Exactly. Will the most valuable, heavily relied upon skill of the future radiologist actually become knowing what not to report? The next time you look at a medical image, remember the physics happening just beneath the surface. Thanks for joining us on this deep dive.